All right. Good afternoon, everybody. Today is June 28th, 2023, and it is 1:04 p.m. As a quorum of the board is in attendance, I would like to call to order the meeting of the Central Health Board of Managers. First item of business is public communications. Members of the public who wish to make comments during the public communication portion of the meeting must have registered with Central Health via the online form or by telephone no later than 11:30 a.m. today. Yvonne, did anyone register to make comments to the Board of Managers meeting? Okay. All right. No one was signed up to speak for public communication, so thank you very much. We will now proceed to the regular agenda. We will be taking up item 3 first because it's very brief, and then items 1 and 2. Agenda item 3, discuss and take appropriate action to create the Central Health Board of Managers Medical Committee. Members, a couple of years ago when Sherry was chair and I was vice chair, a committee called the Medical Executive Board was created. And this was created because a bill passed that allowed us, Central Health, to enter and manage the practice of medicine. According to that bill, however, the Medical Executive Board could not report directly to the board. Sherry and I misunderstood that part of the law, and so when we looked at the bylaws, we deleted the medical committee because we thought that the Medical Executive Board was enough. But we need the medical committee to be able to be a liaison to the Medical Executive Board. And so it has to be recreated, and we will be having a meeting soon once it's recreated. So, any questions? Hearing none, do I have a motion? Manager Musaitis?
Yes. I move that the board approve the creation of a Central Health Board of Managers Medical Committee, including necessary amendments to the bylaws.
And Manager Brinson?
I second.
I have a motion by Manager Musaitis. I have a second by Manager Brinson. Any further discussion? Manager Jones?
Just for the benefit of the audit of the community, could you state the reporting structure for the medical board and then this medical committee to the board of managers so that everyone's clear on what that structure is?
The Medical Executive Board is actually run by the Chief Medical Officer. He's the chair of the Medical Executive Board. And that Medical Executive Board is an independent board within Central Health. And there is a communication that takes place through the medical committee that we just created. And that medical committee would refer any actions or concerns or policy conflicts or anything to the regular board. Okay.
I understand, to make sure that those who are listening out in the audience understand.
Okay.
So all of those still are ultimately reporting through whatever mechanism to the board of managers.
That's correct. Manager Kitchen.
Just related to that independent, maybe just speak to the decision-making of that board versus...
Of the Medical Executive Board?
Yeah, that might help people understand.
I might need John up here to talk about that.
What do they make decisions on versus what?
Yeah.
I think my computer just crashed.
It might have.
What's the ball?
That is why you need a
I'm
method.
having some technical difficulties.
I gather. Some major technical difficulties.
Those are bad beeps.
Very bad timing.
So, Manager Kitchen, to answer your question, the purpose of the Medical Executive Board is to really ensure the independent practice of medicine and have physician oversight of that practice of medicine. So, the Medical Executive Board has several different committees that Alan appoints other providers to that include our credentialing committee, our peer review committee, pharmacy and therapeutics. There's a research committee, quality committee, and probably several other work groups and committees within that overall structure. So they set policies and procedures around the practice of medicine. They make formulary decisions. They make credentialing decisions on providers in our network, as well as the providers that practice directly for Central Health and the privileges associated with those providers as well.
And previously, a lot of that responsibility was the responsibility of the medical committee before we got into the business of the practice of medicine. So in essence, when we transferred that, we mistakenly felt that we didn't need the medical committee anymore because we transferred all those responsibilities to the medical executive board. But we do need the medical committee. That's our liaison to the medical executive board. Manager Musai.
Can you tell the community who it will be on that committee?
Yes.
transparency.
It'll be chaired by Dr. Zamora, Dr. Brinson, and Dr. Martin, and Manager Musaiti are the members of that committee. Any other questions? Okay, hearing none. All in favor? Aye. Any opposed? Any abstaining? Motion carries. Great. Agenda item number 1. Receive an update on the implementation of the Healthcare Equity Plan, including operational and financial sustainability planning. Monica Crowley, Alan Chalsha, Abby Sharma, Danielle Srinivasa will be presenting, and I'll turn the floor over to Monica.
Thank you, Monica Crowley, Central Health, and thank you, Board of Managers, for attending today at this special called board meeting and braving the heat. We are all very excited about this board meeting because the presentation today is the next step in the work that the Central Health Board directed us to begin 3 years ago. This is it's the culmination of the next part of this very important work, where for the very first time, Central Health took an independent approach as the hospital district with the view of the people that we serve in mind, looking at data based upon the needs of the safety net population and looking at the responsibilities and obligations of a hospital district to determine, starting 3 years ago, what the component parts of a comprehensive, high-functioning safety net healthcare system would look like for Travis County. The Central Health Board of Managers recognized, as did the Episcopal Health Foundation, one of the primary kind of think tanks and funding foundations for healthcare, at least in this part of the country, that not only were we on to something as an institution, but also that this is Central Health's work to do, and that no other organization in Travis County is responsible for or was stepping up to take this comprehensive kind of approach to designing a healthcare system. It is our responsibility to provide medical and hospital care for Travis County residents with low incomes across an entire continuum of care. Partners that we work with today and historically may be responsible for pieces of this continuum, but the hospital district is the only organization that is responsible for that entire continuum. And so the Episcopal Healthcare Foundation has provided over the past 2 years more than $1 million in funding so that Central Health could work with consultants, and Guidehouse was the consultant that we've chosen to work with, that we've engaged, to help move the design of this comprehensive system from concept into something that we might implement. Dr. Sharma, Dr. Shalsha, and Ms. Srinivasan are going to give the presentation, and so they're going to go into more detail about where we've been and where we are today. But you remember the Central Health Board adopted our healthcare equity strategic plan in February of 2022. You've seen a number of presentations of how we have begun to implement projects to address the needs that were identified in this plan, and on the continued development of what we are presenting today as our healthcare equity action plan over the course of this year. Today you will see proposed staging of initiatives to address these needs and estimates of cost over the next 7 years to sustain this work. This will be a meaningful investment. It will take years for us to fully implement, and it will fill gaps that exist today that we've become good to fill, but that are meaningful gaps and needs in our community, and will result ultimately in the delivery of comprehensive health care to low-income residents of Travis County that they do not have access to today. And if Central Health does not do this work, no one else will. So thank you so much. Danielle.
Thanks, Monica. Good afternoon, everybody. So, like Monica mentioned, we are going to provide a quick overview of a couple of things to this. The first one is we want to make sure that we provide a progress update. So the last meeting that we had with the board, sorry. Okay, so just taking a couple of steps back, the last meeting that we had with the board was really engaging for all of us. There were good questions asked, and there was some feedback that was given. So we've tried to incorporate that feedback into the material that we are going to share with the team today. There are 4 things that we want to go over in the next hour or so. The first one is we want to provide a progress update. So we've been on this path for quite some time. We want to focus on where we are and also what we've been able to accomplish till date, and also talk about what comes next. We want to specifically focus on the data-driven process that we have used to walk through the different steps in our approach and what some of the products of that approach have been. We want to quickly switch over to some of the products that have come out of that approach. So the first thing that we want to share with you is a high-level Gantt chart that shows how the initiatives would be sequenced over the next 7 years. And then we also want to talk about the outputs of our financial models. So for the initiatives on an annual basis, what are the expenses that are required to stand those initiatives up and also to keep those initiatives running? So we want to do that, and we want to leave time towards the end for questions. Next slide, please. So this slide here, you've seen this slide multiple times, but it provides an overview of where we are and how far we've come. So we began this process 1.5 years ago. The first order of business was to look at what areas in the community exhibited gaps and creating a strategic plan that Central Health would then use as a guiding post to close those gaps. After that, we start thinking about, okay, we know what gaps need to be closed. How do we actually go ahead and do that? That then dovetailed into this phase of work, which started with us identifying the key initiatives that would be required to close those gaps. Now, if you think about the hierarchy of how we have identified what needs to be done, I want everybody to understand that we started with community needs. So where do the needs exist? what is the scale, scope, and magnitude of those needs. The second thing was initiatives. What are the high-level activities that need to be done to close those gaps and address those needs? What we also did for those initiatives was we dove one level deeper and identified projects that would make up each of those initiatives. So again, the hierarchy is needs drove initiatives and initiatives drove projects. Where we are right now is we have a fairly good understanding of what initiatives need to be stood up, what are underlying projects that will help us execute on those initiatives, what's the sequencing of those initiatives, and what some of the high-level costs for each of those initiatives would be. What we want to focus on in the coming months is to also think about the governance model and the reporting structures that would underpin the execution of those initiatives. Next slide, please. So with that in mind, what we started with was this North Star that we called the high functioning system of care. And I'll ask Dr. Schulcher to provide his thoughts on that.
Thank you. I'm going to stand too, since it seems to be the thing to do. Good afternoon, Board of Managers. You all have seen this graphic before. As Abhi just said, this graphic represents components of a high-functioning healthcare system. We've shown it to you before when we've spoken about our healthcare equity strategic plan, and we're now showing it to you as we move towards our healthcare equity action plan. My goal of speaking with you today is really to share some objective successes over the past year and a half, and work efforts that we have jointly achieved while we have been working and moving forward on our strategic plan, mostly to concentrate on what is in store for the future or in the future, and the access and resources and scope and scale that we're working towards for our patients. So I'm just going to give a few examples and then point towards the future. Respite. About a year and a half ago, we started with 5 respite beds. We transitioned to 10, then we went to 15. Dr. Audrey Kwong and her team have decreased hospital and ED utilization by about 75% for the patients that have spent time in respite when looking at the 6 months that follow their stay with us in comparison to the 6 months that preceded their stay in respite. They have made hundreds of connections to direct patient care, physical care, and mental health care, and they removed hundreds of barriers of care or barriers to care when we're considering the social determinants of health. So whether it's looking at the coordinated assessments for the housing or actually housing patients, connecting them to SNAP benefits, whether it's getting them IDs or Metro passes, we really can celebrate their work. Now, when we think about what is to come, a year and a half from now, when we actually have the ability to own and operate 50 respite beds, alongside those respite beds, where we provide access to medical detox management, when we incorporate a high-risk clinic in that same environment, provide an opportunity for our patients to have access to PT, OT, speech, pharmacy, nutrition, social workers. The build is significant, but the opportunities for our patients to progress in their health and well-being is much greater when looking, forward in the upcoming 7 years and the build that is moving forward. When we look at specialty, in the next few months, we'll be opening our specialty clinic. We will provide access to over 30,000 encounters in specialties GI, cardiology, nephrology, neurology, podiatry. I'm forgetting one. There are 6. But alongside the access to specialty, again, we're looking at those wrapped services. So we're looking at pharmacy, dietitian, social work. We're looking at patient navigation and providing diagnostic and therapeutic procedures alongside, those opportunities. In addition, when we look a year and a half in the future, we're pointing to Hancock. That will afford an additional 60,000 specialty encounter opportunities to not only increase access to specialty, but to add additional specialty and additional diagnostic and therapeutic opportunities, right? So within the course of 3 years, we're going from where we stand today to over 100,000 additional encounter opportunities and access points for our patients. Dr. Amali Patel just got an impact award from the University of Texas Internal Med Department for the impact that she and her team is having on developing an infrastructure for transitions of care. If you think about it, we started that about a year ago. We now have RNs in Seton, Maine, and in Del Seton, both on the floors and in the EDs. And for Hamali's peers to vote for her as having the highest impact over the course of the past year is significant. We're just starting, right? Think about the effect that we'll have when we not only have RNs, but we have community health workers, we have social workers. We're not only in the Ascension hospitals, but we're now in the other hospitals around the county as well. We should really be able to do more hand-holding, and the successes of our patients stand to be much higher with the investment and the support that you all have provided us and our teams. In addition, when we can manage patients in when we can manage patients in skilled nursing facilities, which is just a few months away, and when we can help manage patients and care for them in an at-home care environment, again, the opportunity for our patients to succeed is much higher. When considering primary care, thanks to your advocacy and your support, we're providing care by other methodologies, alternative methodologies. We have expanded and increased the capacity for same-day visits. We are opening clinics on a monthly basis, and we're building clinics. So the capacity for access for our patients is significant, again, when looking at the next 7 years. Hippocrates said, healing is not only a matter of time, it's a matter of opportunity. Thanks to the support and the advocacy of the board, the next 7 years look very promising for our patients because they will now have the opportunity for significant healing and increased well-being based on the services that you all are supporting and advocating for. And with that, I will hand it off to my colleague.
Thank you, Dr. Chalcher. And congratulations on those accomplishments. We work with systems all across the country, but those accomplishments are really significant, Dr. Chalcher. So, as Dr. Chalcher mentioned, this is what the ideal state healthcare system looks like for especially a safety net provider system. Now, when we think about the North Star, as Dr. Chalcher mentioned, we've made significant progress. But there's still more that needs to be done. As Dr. Chalcher alluded to, the next 7 years are going to be critical. So if we move to the next slide, it actually talks about how we are going to make sure that we take a data-driven and equity-focused approach to moving into the future. So one of the key aspects there is for us to create operational roadmaps at the initiative level that would essentially be playbooks that staff across Central Health could use to stand up and maintain initiatives. If you think about the operational roadmap, it includes 3 things. The first one is the purpose for the roadmap. The second is the how that initiative would be executed. And the third one is the expenses and the costs that would be associated with standing those initiatives up. Now, at the end of this engagement, we will have these roadmaps for the initiatives that would go on the timeline for the next 7 years. The next slide, please. Now, our process to get to those roadmaps began, like I mentioned, with taking an equity-focused, data-driven, and inclusive approach. We went out into the communities, we talked to patients, we talked to organizations, and we also talked to key leaders in the community. Our goal there was to understand what the magnitude, scale, and distribution of needs in the community was. That was our starting point. We wanted to address needs in a data-driven way. Now, as we looked at the list of needs, there was a lot that needed to be done. And in order to prioritize what we went after first, we created the strategic plan. Now, the strategic plan gave us the what. What do we need to do? And after that, we transitioned to the how we actually get it done. So once we transitioned from having a strategic roadmap, the next step that we undertook was we looked at the individual needs in the community and we identified, like I mentioned, initiatives that would be required to meet those needs. Now, if you move to the next slide, it talks about what happened after we identified those initiatives. So if you look at the purple slide on the left, it just talks about one initiative. And the individual text boxes that make up the body of that slide are the projects. So what I said at the outset was the hierarchy of our approach was needs drove initiatives, and then initiatives were actualized through projects. So the purple slide here talks about what those initiatives were, and then for each of those initiatives in these text boxes, we have individual projects that are required to execute on that initiative. And as you can imagine, each of these initiatives is made up of multiple projects because some of these projects are IT focused, some are staffing focused, some are project focused, and in order to stand an initiative up, you need to address each of the critical capability that makes up that initiative. Next slide, please. So this slide and the following slide gives us a list of initiatives and the needs that those initiatives are addressing. We bucketed these initiatives into categories that were driven by criteria that focused on the primary point of care. So the first big bucket that we had was primary care, we had specialty care, and then we had hospital-based care. In the blue text boxes that are underneath each of these category headers, we had the individual initiatives that made up that category. So if you look at primary care, if you look at mobile care clinics through to patient navigation, those are the individual initiatives. This exercise yielded 38 individual initiatives that were required to meet needs across the community. Now, it's evident from the slide that if you look at the specialty care bucket, that bucket has the highest number of initiatives. And if we were to, when we get to the finance slides and the slides that show the outputs of our financial models, you will also see that this makes up the biggest cost bucket from amongst the different initiative categories that we have here. If you move to the next slide, that also gives us the same view, but here we focus on foundational enablers. So what are some of the cross-cutting things that are required, agnostic of where that care is delivered, that would actually help us enhance the delivery of care? So the first thing that we have here is IT. For Central Health to move over to a direct care model, the IT infrastructure needs to be stood up. So that is one of the foundational enablers. We also have enrollment and eligibility. So as we think about expanding access, we also want to make sure that people who are not part of the system are part of the system, and for that, enrollment and eligibility related initiatives will be required. Pharmacy is right at the center. So all of these patients need to be prescribed treatments. And for that, a pharmacy function that cuts across different points of care is critical. Care coordination is the glue that brings everything together. One of the things that is especially prevalent in safety net populations is the continuity of care for safety net populations is more fragmented than for a Medicare or a commercial patient. So as we think about making sure that people stay engaged and don't fall through the cracks, we need to focus on care coordination. One of the key drivers for our approach was equity. And the way we brought equity into our discussions was through social determinants of health. So we looked at social determinants of health, impact of these determinants on access, quality, and outcomes, and then we included some of the tenets that make social determinants of health into our approach so that we came close to ensuring that individuals are getting equitable care across the system. We also wanted to focus on coverage programs. So as access increases, we want to bring more people in. So what can we do with our coverage programs to ensure that the safety net is getting bigger and more patients are actually eligible to seek care within that system? Next slide, please. Now, this slide here talks about some of the key considerations for us to execute on the action plan. Now, if you think about what we need to do here, the one thing that I want to stress on is trade-offs. So we have a lot to do. Most of that is important for us to do, but if you look at the expenses that would be required for us to do all of this, we need to make trade-offs. And those trade-offs have to be based on the scale and scope of the need, as well as the fiscal capability that we have to cut through those areas of need in an incremental fashion. If we move to the next slide, it actually gives a high-level view of what the sequencing of some of these initiatives would be. Pass it to Danielle to take us through the slide.
Thank you, Ravi. So what we see right here is the high-level roadmap for execution on this health equity action plan. But even before we got here, there were a few guiding principles that we really adhered to even put this together in front of you for today. So number one, going back to a comprehensive data-driven approach. We know that there are significant unmet needs in Travis County. So what does that roadmap or plan look like so that we can make the most impact and address those most significant needs across our patient population? So with that said, we considered quantitative data. So what are health outcomes and access look like today? What does the utilization look like for some of the most significant health conditions? And then what is that voice of the community? So what is our community saying in terms of how they access the system, and what are some of those critical success factors look like to them as we develop this high-performing, equity-focused system of the future across Travis County's safety net? Number two is really understanding and going back to the voice of the community. So the plan that we have in place today is meant to be adaptable, to be flexible. We know it's going to evolve as we continue to move forward in the future and that their needs evolve. And then lastly, we are going to continue to rely on that voice of the community to really assure that as we execute, that our community is engaged and that we continue to meet their needs in the most impactful way. So when you look at this plan here, we've deployed several strategies to use our resources in the most effective, impactful way, but then also considering that voice of the community. How do our patients engage with the system, and how do we make it easy to drive equitable care? So what you'll see here is this high-level timeline across these critical priorities and initiatives. And what we're seeing is time to implement, execute, and operate for these major strategic priorities. So the dark blue bar represents the planning, execution, and scaling timeline. So it's our time where we're really focused, we're implementing, and then we're continuing to build out and scale. So because we know it's going to take time to reach some of these hard-to-reach patient populations that we're not currently engaging in with today. And then the light blue represents operating. So that's our ongoing operations that we're going to continue post-implementation and execution. So I want to draw your attention to these yellow stars. So these represent major projects that are going live. And what you're going to notice is that there's some duplication in some of these projects. That is intentional. So when we look at, say, primary care, dental care, and access to specialty care, we have designed sites that are multidisciplinary in nature to make it easy for our patients to engage with us, where they can come and receive the care that they need in one visit, to address some of the social determinants that impact how they access the system, and then also to really maximize how we're using our financial resources. So how are we spending our money? We're developing models that are incredibly adaptable and flexible to really assure that we're having the most impact as possible. So you will see here some of our our near-term initiatives start with primary care, specialty care, and dental. And then some of the initiatives that will take a little bit longer or further out, building on the success that we will have with primary care, specialty care, and dental, include post-acute, mental health, and then that longer-term acute needs planning. You're going to notice, you're not going to see a dark blue box for some of these foundational enablers. This is work that we have underway today that we're going to continue to build upon and scale as we continue to build out and address these community needs. Next slide, please. So the financial impact of these initiatives is fairly substantial. So as we consider the impact, we've designed a financial plan that relies on our ability to maximize use of resources. So what does that mean? Our financial plan will utilize resources that will not touch just one project. We are not going to work in silos. Our community is asking for a multidisciplinary, coordinated system of care, and the model that we have developed addresses those needs. So when we look at the cost to implement, you'll notice the financial operating costs increase over time, which is intentional to build on the prior year's work, so building upon our successes. Next slide, please. This is a very detailed slide with a lot of numbers on it, but essentially gives you a detailed look at the operating expenses associated with addressing each significant community need. So you're going to notice again that multiple initiatives will drive impact to addressing these community needs, and we have designed models that are flexible, multidisciplinary, cross-utilize resources so that we are being great stewards with our financial resources to address these needs. And you'll notice here too that these are aggregate costs that build upon the prior year so that we're growing strategically and mindfully so that we are successful in our execution to address these needs. Next slide, please. This slide gives an overview of some of the non-clinicals, so some of the support functions. So you'll see here, so what are some of those wraparound services to make ourselves successful and provide that necessary infrastructure as we continue to scale and expand our services? So human resources, finance, communications, general administration, strategy, and compliance are some of those major categories. What I'd like to highlight here is that the Central Health team with Guidehouse has spent tens of hours working through this financial model so that it is the most accurate representation of what the future looks like. So significant due diligence, benchmarking, and projections went into this that included representation from the entire Central Health leadership team, as well as staff across various departments to make sure that we had the best possible input to inform you today. Next slide, please. So where do we go from here? So we have an adaptable, flexible financial and operating model. And over the next month or so, we're going to start designing some of the key performance indicators to really assure success. So what do those KPIs look like over the near term? And then how do they need to evolve over the long term? And then what are those operating models that will be required, near term, long term, to execute successfully? So we're going to fine tune these financial projections. That is something that will continue to evolve on a regular basis as we know that the environment evolves and the way that we address some of these needs may change based on feedback that we get from the community. We'll complete the operational roadmaps, including that sequencing and phasing, so near-term, long-term. And then we'll continue to develop the oversight and operational alignment models, including those KPIs. That brings us to, I think, the questions portion of this.
Yes, thank you, members, for allowing us to present this information to you. I think the next action is, for the board, you're going to have more time with this information, but in August, we'll be asking you to validate or ratify what you see here as we build out the budgets, and that's an important action and a board prerogative. But I wanted to spend just a few moments just to put some commentary around this, because you've heard, we started out talking about with Alan's discussion around, actually Monica's discussion around, this is historic. This is precedent setting, but it also is impactful if you think about it over the long term. And then we heard about, and hey, there's work that's happening today. This is just not some kind of ideal, but we've got some building blocks that are very, very real, having very real results in people's lives today that are allowing us to be able to do this, because you all have supported this work over the years and here today. And then you've seen this is what the roadmap and the fiscal investment is to be able to help people live the healthiest life possible. So this was a very deliberate design in terms of the discussion, but there is one piece that does bear mentioning. And as organizations, and this is not unique to government organizations, it happens across the spectrum of organizations, there's a lot of time spent in meetings on ideation, visualizing, and coming up with the best of intentions. And that's good. That's a part of the human experience. We need to do that, because if for no other reason, it gives us hope. But at some point, you have to double down. And you have to get operational plans in place, and you have to be willing to make investments and take that, from the state of ideation and visualization and intention making, and start to turn it into a bigger and better reality than what people expected you to be. And that's where we are. And I think your biggest challenge, our biggest challenge as an organization, is there's going to be a lot of well-intentioned ideas out there. But when you look at this North Star and the roadmap that's set out before us, the boards, not this board, well, this board plus future boards, are going to have to make a deliberate decision. We're going to stay focused on this, because this is what our patients have told us what their needs are. This is the steps that we need to take to be able to get there. And to deviate from that means going back to the communities and the groups and saying, there was this other shiny object that we just felt compelled to reach out for, but it's going to cost. And that cost is going to be in resource allocation and people, time, and money. And so that's going to be a big challenge here. And I say this because budget season is upon us. And I think these remarks are timely and relevant, because you will be petitioned in various ways. And ultimately, it's the board's call. You could chunk all of this, all of it. But we'll just be going from one fiscal year to the next to satisfy or to reach out for this object when you've got something much bigger in front of you. And so I know that this is not lost on you. You all see this, but we're in a public meeting and wanted to get this memorialized as the board moves forward. But thank you for allowing me to make those comments, and as always, indulging me. Thank you.
Thank you, Mr. Giesman, appreciate it. And thank you, Guidehouse. It's been a long journey, but a good journey. And we appreciate all the hard work that you and our staff have put into this and have provided us with real guidance, information that we can use to make a decision and to be able to hopefully, over time, help the population that we have been responsible to serve here in Travis County. So thank you, appreciate it. And I will go around and ask if there are questions. Manager Valdez, I see you on board on the video. Did you have any questions or comments you'd like to make? I'll start with you. You are muted.
I'm muted. Okay. I appreciate all the work that has gone into this. These are ideas, these are dreams that are finally being realized, that people have been espousing for a long time, at least a decade, and I know because of the work that has been done advocating for patients and for community members. So I just wanted to make sure that, just a couple of things. When we talk about working with our partners and making sure that we are staying focused on closing disparities gaps and making sure that our healthcare system is developed as an equitable model, how are we going to be monitoring those partnership relationships and whether or not our partners are actually doing what they're supposed to do? On one of the sheets that talked about mental health, I know that we fund Indigo Care. I also know that Travis County is coming up with a district, I guess it's, hold on, I lost you. A center to deal with opioid, substance abuse, and mental health issues. How are we going to make sure that they are doing their job and that they are producing what we need for them to produce? And then additionally, I'm assuming that as we look at these projects, I think you had said 150 or 150, whatever it is, these projects, I'm assuming that we're starting with internal projects within Central Health, within our organization, because what we want to do is make sure that we are and have the staff and are working on ensuring that we are equitably addressing the needs, the medical needs and healthcare needs of our targeted community first. Expanding MAP Basic, making sure that all our patients get access to the best care that they possibly can, and then bringing in as many of those 200,000 uninsured Travis County residents as we possibly can. I just want to make sure that I'm assuming you are, that there are plans on how that will be monitored and will be prioritized. And then let's see, looking at the SDOH contracts, I know this is starting at 1.3 million and you're going up to 2+ million, which may or may not change. And what are those for? Aside from having promotoras or social workers that will help refer our patients to those entities, like governmental entities or organizations that are already doing this work, sending our patients or referring them for services, we're not doing that. We're providing for the access for them to get that information from our, I'm assuming our case managers, our promotoras, and social workers. How is that going to be addressed? And let's see, because we want to make sure that Travis County, the City of Austin, Indigo Care, and all those other partner organizations do their job and don't just slack off and expect Central Health to pick up the cost of doing their job. No, I don't think that that's what we should be focusing on. Also, when you talked about the Seton, we already have staff in Seton hospitals and now other hospitals. I'm assuming you mean St. David's and Baylor Scott and White. And with all we've been seeing for the last couple of years with how Seton is treating its doctors, that they're leaving in droves, the nurses are leaving, blah, blah, blah. How are we monitoring the quality of care that our patients in those facilities is being provided in light of the fact that there are significant staffing issues that at least one hospital, and that's Seton, has not been able to stay on top of. So those kinds of things, I just wanted to make sure that we're not putting them to the side because they do affect overall the impact. But let me tell you, this is a very, very good, great step in moving us in the right direction. So I want to say that to everybody who's working to make sure that this becomes a reality.
Thank you, Manager Valadez. Did you guys have any comments or responses?
Yeah, I can. So I noted down 4 questions, Manager Valdez. So the first one was around partners and how we keep them accountable. So in the upcoming months, we will be working on KPIs, so key performance indicators, that would help us track how our partners are performing, and a accountability process that would ensure us to have conversations with them as needed.
And also, I think part of the plan involves significant investments, ongoing investments in data integration, data governance, and sharing that feeds into and supports those measures and KPIs.
That we're putting into place a patient follow-up, I'm assuming, a patient follow-up process so that we know directly from our patients that are receiving these services whether or not the follow-up care is or is not being provided. And so I appreciate that. With respect to the organization, the hospitals and monitoring the care that is or is not being provided currently, and how is that going to be addressed?
Manager Valadez, one of the things related to ongoing litigation and potential breaches of contract and that obligation between our hospital partner is something that, because of the ongoing litigation, we're not able to talk about in open session. So
I'm
monitoring.
not talking about litigation.
Yeah.
I'm talking about what is in the news. I'm talking about how the unions are getting their nurses to quit because the nurses and the staff at Seton are put at risk, not being safe. The patients are not being safe. This is public information. This is not with respect to litigation. I want to know how we're monitoring that and to make sure that this doesn't happen at any of the other hospitals that are receiving our patient population. That's what I'm referring to. Let's not get confused with litigation issues. I'm talking about the nurses walking out, the doctors refusing to practice anymore because of the political policies that are being put in place by the hospital board. That's what I'm referring to. And when their nurses are telling you and staff is telling you that we are at risk every time we walk into that hospital and our patients are at risk, how are we going to monitor that? Because those are our patients that are going to be. And it's not it may be right now with Seton, but I want to make sure that we stay on top of what is happening, what may or may not be happening at other hospitals in Travis County.
Yes.
Those are just considerations. Those are things you can talk to me about, or at least consider whether or not they're valid. I'm just proposing that.
We'll do that. We'll do that.
Thank you. I appreciate that.
All right. Manager Martwani. Thanks. No. Manager Martin.
Thank you, and first of all, thanks for the great work. It's a ton. I did have a couple financial questions, and that is, for example, and this is just an explanation. For example, when you talk about expanded access to specialty care and you give us a number, is that number to be interpreted as, like, say, procedures done, say, dialysis, issues that have to be dealt with, actually the charge of colonoscopies, for example? Are those numbers calculated in that, or just clinic visits?
So we did a bottoms-up analysis, Manager Martin.
Mike.
So we did a bottoms-up analysis where we used patient volumes as the input, and then we used MGMA and definitive to benchmark what the procedures and encounter volumes would be for a given patient base. So if you think about the specialties that are covered in that bucket, all of what you mentioned is being accounted for in the yearly projections.
Okay, thank you. Another example or question is related, say, to pharmacy. So from 2028 to 2030, pharmacy expenditures go up only by $300,000. That's 5% over essentially 3 years. Simply the cost of pharmaceuticals rising at the rate they are, and assuming the increase in number of patients, is that a realistic number?
In the baseline budget, there are, Jeff, is that a 5% increase or 4% increase year over year? So we have 5%. So these are representative of added incremental cost or estimated incremental cost year over year of providing the additional services. Also included in the overall budget is this 5% inflationary cost that's in a different line, but that's incorporated into that baseline budget that captures these increases in pricing. And I think that typically the Medicare and Medicaid inflation hasn't been as high as 5%. So I think for the finance team, they say by having this 5% inflator, it's a conservative increase to capture that inflation.
I'll take your word at it.
But if I may, these are the costs of the initiatives that we're referring to, not the ongoing costs of
we're looking at it.
pharmaceuticals and increases over time. Is that another way of saying it? Okay. And just for the record, the person off camera that was speaking was Jeff Canolo, Chief Financial Officer.
Thank you.
Okay. Jeff?
I may not,
Mr. Canode?
sorry, I may not have heard correctly. I thought you said 300,000. The amount is 3.3 million.
No, from this year 2028 pharmacy expenses.
Are 5.6 million, 2030 to 5.9 million. So the course of 3 years, it goes at 5%.
So the cost that you see, the estimated cost in these charts, these are incremental increases. So we still have our base budget, and that's what Monica was talking about. So our base budget plus the inflator amounts that we assume. I think the thinking, or at least my thinking on the pharmaceutical is as we build up our specialty care practice, that will increase, or we would expect to see our pharmacy cost increase. And that's what this is reflective of, are the additional services and the incremental cost associated with pharmaceuticals.
But not the actual cost of that drug acquisitions, for example? Or yes or no?
It's in the baseline, right?
Okay. Thank you.
Thank you, Manager Martin. Manager Musaitif?
Well, thank you. Really appreciate the presentation and your work. It's been almost a year now or so. I have a few things, if I can. The first one, I really appreciate the roadmap that you have outlined to us. One thing in terms of specialty care, and something going back to the community's voice and needs, is cancer care. So is that part of the specialty care component? Like, I want to know what's the plan that you have to address for our population, because it's not really clearly underlined here. And I just also, in terms of social determinants of health, I don't see a connection. I'm just wondering, like, why you have it outlined, the diagrams here, and how what's your plan of integrating that into the system in place. And the final thing that I have, there's a lot, but in terms of our operating costs, Now, I'm thinking about our budget and our needs and how to restructure it and over time, because if we're looking at 2030, time flies and it's about a quarter or more of our budget and our needs, competing needs, and we'll need to reshuffle how we provide care to address all the issues that we have, all the projects and the care that we need. I'm just want to know, is this a conservative number that you have? And also as we're approaching to our budget season, is this, I know these are the priorities that we're focusing on within this plan, but what about the other things that we have? And I want to make sure that we have a sustainable financial model to ensure us that we are doing this work, in addition to everything else that is being asked from us from outside, that we are doing the right and just thing. Because what I know in terms of fragmentation of care, because I would hate for us to start something that we're unable to continue on. And if we are able to continue on, we need to downsize in terms of capacity. So that is a fear that I have. I just want us to address that, because our budget is very finite. So, sorry, I know you may not have all the answers, but these are the concerns that I have. Thank
Well,
you.
if I may, team, as Jeff Knodel comes up to answer some of the financial modeling questions and what we're going to be presenting to the board, I'm going to actually take the last part of that question. And that is, when you talk about sustainability, that's at the crux of it. You don't want to roll anything out and open the doors to patients and not have any idea if you can make it last beyond 1 year. I want to commend the team on healthcare delivery, because that's precisely what they have avoided successfully by testing and piloting. And while those sorts of things take time, we're able to offer assurances to patients that when we stand up nephrology, we're standing it up for you for as long as time lasts. And that's an intention. And so I think if this board will continue to allow the space and the understanding and the perseverance to stage things properly, test them, pilot them, and scale them up appropriately, then we can meet that sustainability goal, Manager Musada, that you've stated, so that we never have to call up a patient and say, we're going to discontinue this specialty line because we can't make it work anymore. No one wants to make that phone call. And so I think if we continue with that approach, we'll be successful.
Thank you, Mr. Keeson. Any other comments?
And I guess I'm going backwards in order of the questions. I'm going to take the second one on the social determinants. And this also gets back to Manager Valadez's question. When you look at the social determinants that we are really focusing on, these are ways of addressing social determinants. This is a health care.
Sorry. You know what my favorite show is.
Now we know how you spent your late spring. With that healthcare equity action plan, it really is focusing on healthcare. And so much of that investment is in ensuring we're able to scale up transportation services to get people access to the healthcare services that we are expanding. So much of it's focused on transportation, care coordination, and standing up our navigation center. So we're continuing to make significant investments and scaling up some of the things that we do today that also are things that don't overlap with what other organizations are responsible for and have funding for, but are things that really are specific to the work that Central Health is doing, so that we can make these connections. So that is one of the ways that is integrated. If you remember when we started, and if you talk about how things are depicted, those 5 areas, when you have the foundational laborers, you have the primary, you have the specialty and hospital, you have, post-acute, and then you've got the foundational enablers and the social determinants. Those were the ways that the needs broke out in the community needs assessment. So I think we haven't repeated walking through every single stage in every presentation, but the reason we're depicting these the way they are today is because that it's building upon the way that the gaps in the community health needs assessment came out. Dr. Shalsha?
Before I give the mic, this is the power of controlling the mic. There are two areas that are just too important not for me to see how many chairs we can get up here. One is equity and the other is social determinants of health. So they're not initiatives. They're paradigms that we are looking at for every initiative. If you look at respite, and we talked about all the connections made, all the barriers removed, the way we conduct care, we're considering how to meet the patient need. And so it may mean that we have to go with patients to their appointments because that's the way that they'll understand the care and that helps in their success. It may mean that we have to recruit community health workers from a Vietnamese community, from a community that speaks a unique language that we don't have, those folks on board. We need to look at the care per community and look as to what the build is for that community in order to meet that need. And that means removing the barriers and considering an atypical approach in every environment. So it's a paradigm that we consider as we move forward.
Yeah, thank you, Doctor. Okay. To go back and answer the question you had, the financial question, I think one of the advantages of having Guidehouse help us in this engagement, you asked, are we using conservative numbers? I would say we're using realistic numbers. I think they helped us benchmark some areas that we may have not had as much information on, and when you don't have as much information, you tend to be more conservative. So that's how I would characterize the estimates that we have thus far. And then you asked about sustainability. How do we ensure that we're putting a plan in place that we're able to achieve what we set out to, what we were planning to achieve on the plan? From a financial standpoint, our objective is to take this plan and work it into our forecasting model and come back to the board and show the impact of this model. And remember, when we do a forecast, it's over an extended future. So we will look at this period of time, the 7-year period, and convey to the board what our financial picture would look like incorporating the plan. So that's the sustainability part of it that we're trying to complete prior to budgeting, just so we're able to move forward into the budgeting process from looking at a longer term financial planning process.
And then I'm going to hand it back to Dr. Sharma for the first question, but I do want to point out this does also include not everything, not every line item on this plan is an expense related to a service line that Central Health is directly providing the care in or is anticipating to directly provide the care in. There are also expansions with contracted providers. There are expansions for, and particularly in the cancer area for screening and prevention. Central Health will be working across our primary care continuum to participate in projects and work like some of the CPRIT work for scaling things out to our entire population for screening. And we're also adding services related to radiology and potentially oncology with other contracted providers. Also for other parts, expanding things from just the MAP population to MAP and MAP basic. So this is included, and then I'm going to hand it off to Dr. Sharma for more nuance.
Yeah, like Monica mentioned, we are taking a continuum of care approach to addressing cancer per se, because as you can imagine, the interventions and the services that are required depend on where in the continuum that care is being asked for, right? So primary care, before that prevention, and once you're diagnosed, So we are taking that into account, and wherever those services are represented within our framework is where the cost is being allocated. So if it's primary care, it would be in the primary care bucket. If it's specialty care, it is in the specialty care bucket as well.
I think one other point there too is that is when we think about cancer, it's about building equitable access. So the system has been designed so we're minimizing those late stage diagnoses. We're getting patients in sooner by building equitable access, and then we're improving quality of life and the longevity of life. Specific to cancer, when we think about the model, it's not just access to the specialist also. So when we look at some of the uniqueness of what we presented to you today, it's also thinking about that role of the community health worker and how do we manage symptoms, right? So that patients that are experiencing challenges in their cancer care have direct resources to contact so they know what to do, and then they're not presenting in the emergency department feeling, very sick. So we're helping them on the front end. So we've designed a proactive, coordinated model that touches on a lot of these conditions, of which cancer is one of them, to really improve quality of life for those patients that need care.
Thank you. Management's IT Manager Kitchen.
I want to echo everybody's thanks. This continues to be a very thoughtful, very in-depth work, and I really appreciate all the work that you all have been doing on this. It's exciting. There's a lot of very interesting and exciting aspects to this. So I have 2 process questions and 3 that are more content questions. So I'll ask the process questions first, just to make sure I'm understanding the process. So, and I think you may have spoken to this before, and I may not be remembering exactly, but with regard to public input on the set of initiatives and projects, what's the next step, or do you know yet what the next step is for that?
And I'm looking at our Chief Communications Officer in case I get this wrong. We have a half-day community input event that is scheduled for July 13th.
Okay.
Yes. So it's not just kind of our typical, our events are never typical, but it's not the kind of 1 hour question and answer session or Facebook Live event. This is truly a half-day forum with extensive opportunity for input there.
Okay, and what level of detail are you expecting to share? In other words, is it down to the project level, or maybe you can help me understand that?
Hi, Ted Burton, Central Health. It'll be similar to today's presentation, so a recap of where we've been and where we're going. Mm-hmm. It'll include a opening remarks, a keynote speech, and a panel discussion with some of our in-house staff, and then questions and answers from the audience. And we'll also capture questions from the audience so that if we can't answer them on the spot, we can follow up as we always do with all of our community conversations. Okay. So it's from 8:30 to noon on July 13th at the ACC Eastview Campus Auditorium.
Okay.
I think some of the input that will be, or not the input, but some of the information we'll be sharing about what's currently happening will be at that project level, like you've received, and then for what this plan and the roadmap we're looking at is more at the community need and initiative level.
Okay, thank you. My second and last process question, and then I'll go to the content questions, is just to confirm, make sure I'm understanding what I think I heard, and that is that the next step for the board that is an action item is when this comes back to us as a component of the budget. And the action item is part of us approving the budget. Did I understand that correctly?
Well, first, and I want to make sure I'm saying this correctly, we need to bring this back one more time. I'm gonna use the word ratification, if you will, or validation, because you still need some time with this information, because you just got it. But then, yes, subsequent, when you ultimately vote on the budget, that brings the two together. The objectives that are laid out here and the goals, and then the money to be able to make it happen.
Okay, all right, so what you're referring to as validation is gonna happen before the budget, is that what you're saying?
On August the 2nd, is it?
In August.
Yes, sure.
Yes.
Which is before we adopt the budget?
That's correct.
Yes.
Okay, all right, so then, okay, so that answers my process question. So then I'm gonna turn to a few content questions, just a few. So then, so this page that lays out the dollars, is this, in what stage is this? Is this what we would expect to see on August 2nd? Are y'all still working on it, or how do you feel about these?
What page are you?
I'm talking about the page that's got the numbers on it.
13?
13, yeah, sorry.
Okay, all right.
Let me start out on this
I
one.
just want to make sure I'm understanding where you're
Yes.
at in your process.
Yeah. Again, as Jeff comes back to the table, I'll start. But these are showing you estimates that take you out a number of years, of what
Okay.
each year is going to be, if you will, in terms of investments. Now, the budget structure itself, and I know that's going to change somewhat, and I'll let Jeff or Lisa speak to that. You'll still see these line items. So the budget is not necessarily going to look like that piece of paper, but what's in that piece of paper is, in terms of the first fiscal year coming up in '24, is going to be embedded in that. Now, we're going to need to have, just for, not only for the board's sake, but for the public's sake as well, have some conversations that are a little lengthier than what you've had in prior budget seasons, where we're doing this crosswalk between what you see in this document versus, and then how it's reflected in the budget.
Okay.
So with that,
Yeah, no, I don't have a whole lot to add, except maybe a little longer term. So, from my standpoint, we will continue looking at these numbers.
Okay.
If there are some adjustments,
Okay.
we'll make those. At some point, when we come back August 2nd, we need to put a kind of a stake in the ground. This is based on what we know today. This is what we think it costs over the next 7 years. And then it becomes monitoring and adjusting. So if there are things that are monitoring that require us to make some adjustments over time, I think the budget process, the annual budget process will help us with that. So from my standpoint, it's a living, breathing document that we should be looking at, monitoring and adjusting accordingly if needed.
That makes sense. I guess what this document says to me, and I'm wanting to make sure I'm understanding it, it establishes priorities by year. And when I'm thinking in terms of validating, I'm validating the priorities by year. I understand that the numbers may switch, that this is not necessarily going to be the exact number, and all. But I am validating, I'm being asked to validate these priorities, which is fine. I mean, that's what we need to be doing. So, that's why I wanted to understand from a process standpoint when that was going to happen, and so that's on August 2nd.
I almost begin my answer by telling you that when we adopt the budget, the only thing I can guarantee is it's not correct. But you made the exact point, which is these are best guess estimates, and again,
based
to
on
me, the
authorities.
key is to monitor it, because we do have a finite amount of resources, and we're making estimates, and we'll need to adjust accordingly if, for whatever reason, those estimates are off or under or underutilized.
So this is telling us priorities in order of magnitude generally is the way that I think about it. So, okay, so then now, related questions that I have, just so I'm understanding what I'm looking at. So, this paper that we have right here is the 38 initiatives, right?
This and the next slide.
Pardon?
So this and the next one make up the 38.
Oh, I thought I counted 30 on this page, but it's this and the next page.
Correct.
Okay, got it. I'm not, in the projects fall under one of, okay. I am not tracking the 38 to this page. And I'm also not understanding where the list of projects is. Or how do we see a list of projects?
So the,
And maybe I shouldn't be, maybe I'm misunderstanding the materials. So,
the page that you showed with the timeline, so
Yep.
that is done at the community need level, knowing that multiple initiatives are required to address those community needs. So we're gonna tackle, for example, primary care in a variety of different ways, as is specialty care, et cetera. So there's 13 community needs that so you'll see those swim lanes on that slide, in addition to those foundational enablers. On the following slides, so.
can I interrupt you for a second? Okay. There's 13 community needs, and those relate to the 38 initiatives?
Can you, and just
I'm sorry, I'm
just-
trying not to
yeah,
be too
and
concrete, I'm just trying to understand.
Just getting super concrete.
Oh, yeah.
So we attached a list of all of the projects to, and I think we can continue to provide that in the backup, and we can resend that again. I think that would be helpful.
Yeah, I thought you might have sent it to me, I just want to be clear.
Yes, that was something we provided in the backup maybe 2 presentations ago.
Okay.
But just if you look at the dark blue slides, the dark, not blue slides, the dark blue buckets at the top, there are 5 dark blue buckets at the top of the slide that your left hand is on. And there are 3 there, and then there are 2 on the back.
Got it?
Yes, those are kind of the key areas where we identified gaps during the community needs assessment before.
Okay.
The light blue buckets that are just underneath those represent the community needs. And then the gray buckets underneath those are where the initiatives are. So the
Okay.
light blue ones aren't initiatives, those are the community needs.
Okay. And then the list of projects, is that, is that public?
Yes, no,
Okay.
yes, it is.
Where does the public, I mean, what, I guess what, that's not my question, I'm sorry. My question is, where would the public go to look at a list of projects?
And that would be in the backup for one of the board meetings, although it's something that we can share again.
I can
Yeah.
circle back to that. We actually set up a special section on our website, and of course, not everybody has access to the web, so that's why we have the community conversations to connect with people. But as we take these steps with the board, and we feel like there's enough of a green light that we can put stuff in that website, to, again, kind of gauging on where the board is on this and the level of support, but I think we're at that point where we could start pulling some of the things over to that special website that we set up. And this, Ted and I were talking about this earlier, but there's going to be a lot of, it's not just the community conversation, and this is responsive to your question, there's going to be media cascading around this so that we can draw attention to it, to make sure people know, hey, these are the initiatives that we're working on. If you want to learn more, here's how to do that.
Well, the reason I'm asking that is, and I know, I'm just trying to think through that, is that people tend to think in terms of concrete projects. You know, and it's hard to understand what an initiative means. And that's why when you go to the public, I mean, you need to think through this, but for the public to understand what's really going to happen, you kind of need to share the projects.
Absolutely.
Okay.
Yes, and putting it all out there in the same documents that you all get to look at. I also think, and this is responsive to your comments, going back to what was presented in FY22 to say, we heard you, let's go back to these imperatives. Everything that we're doing here is feeding into those imperatives, addressing the critical gaps in care. And so there's a lot of narrative that I'm skipping over right now.
Sure.
For brevity's sake, but that's absolutely part of the cascade to follow.
Yeah, it may just need to be simplified, need, project, or something like that.
Because
But
the
anyway, I'll leave
concreteness
that to
being,
you all.
Gaps in specialty care.
Yeah.
So these initiatives are going to fill those gaps in
Yeah.
specialty care.
Right.
Just-
Yeah. Okay, my last question then would be, so then going back to the estimated cost by year, and the fact that this is speaking to or representing some order of magnitude and priorities, what were the criteria or factors that were used to determine what year these started? I mean, I guess I can get more specific. So the healthcare for the home, I think you answered one of my questions, so let me just verify. This is new dollars on top of existing programs. Okay, so I know that we do things right now in healthcare for the homeless. So, but I'm gonna use that just as an example to ask my question because it shows no dollars for it in 2024, and then it starts in 2025. So that tells me that there were some criteria used to determine the priorities of when that would start. And so I'm just asking if you could give us some kind of idea of what the decision-making was and what the factors were that arrived at this kind of order of magnitude and this priority for the timeline.
And I would say for some of this, one of the things that we didn't include on this list is the year zero, which is really fiscal year 2023.
Okay.
There are dollars that were allocated to meet identified community needs in 2023 that were additional dollars. And I think some of you remember from the budget season last year, there were additional dollars around things like additional street medicine and mobile care that have been, and respite, that were allocated in the fiscal year 2023 budget in response to these identified community needs. Some of those things, like bringing on additional street medicine teams, have yet to be implemented. But those dollars from 2023 are going to carry over into 2024. They're not new incremental dollars. They were new dollars this year, and so they're kind of carrying forward ongoing budgeted dollars from 2023 that will be implemented in 2024, but it's not new additional dollars for those programs. So there will be, so it is a little bit less straightforward than saying the dollars reflect how things are prioritized, because
Okay.
there are things that we prioritize so much this year that the new dollars are in fiscal year 2023, and additional new incremental projects will come online in 2025. So some of our most prioritized things actually aren't showing up in the priorities because they were prioritized for this year.
So maybe it's more just a matter of providing some rationale around this, because, and you don't have to tell me what the rationale is now. I'm just trying to get to the point about what we'll be asked to validate. I need a little bit more about why. Why this order, why this much, that sort of thing. Does that make sense? Okay, let's see. Oh, and then I just wanted to make one quick comment about the SDOH, and thank you for bringing up SDOH in health equity, and I appreciate what you said, Dr. Shelsa, about that. So I would just want to know, when y'all are putting together your KPIs, how you're going to measure that, because it makes perfect sense. I mean, it is what we're talking about, that SDOH and equity has to be part and parcel of everything that you do. But how do we measure that? And how do we know that we're doing that? So I would just want it to be called out in some way in KPIs. So that may be a KPI that shows us how how we're addressing disparities in outcomes for pregnant moms, for example, or how we're, whatever it is. I mean, you guys know more, better than I what the disparities are, but something so that we can see that. And then the SDOH part of that would be, well, here's what we're seeing are the major barriers. Here's how we're addressing them. Here's the change that we made. Okay, all right, that's it.
Thank you, Manager Kitchen. Manager Jones.
Well, first of all, thanks very much. This is very, very helpful. It sort of brings us a long way, so I appreciate you taking time to do that. Many of the questions my colleagues have asked, so I won't repeat those. But I do have a couple of questions related to, and these may be more theoretical as in terms of population, from a public health perspective particularly. Looking at the population over the next 7 or 8 years that we're talking about, do we take into consideration what that will look like, not just our population, the 200% of poverty or below, but what that changing will look in terms of the strategies that we put forth? Because what we look like, as we look at the demographics of Travis County particularly, what we're seeing is a larger exit out of the county to surrounding counties of populations that we historically served. So the question is, are the strategies that we're developing now going to be relevant in 2028 as they are now? So that's just one thing I want us to consider. The second thing is, and this is a question I don't know if I've ever been asked, is that when we talk about the 200% of poverty, we assume that that's a stagnant figure. In other words, that the population here, that's 200% of poverty or below, remains the same eternally. But it's constantly changing. People are in and out of that. And so the question is the strategies that we have to address those populations culturally, economically, politically, or otherwise. Do we have a strategy to be able to communicate that to that population that is relevant to those particular needs? You mentioned data-driven a lot, so the question is, do we have that data as it changes? For instance, 2023, we know that the population is 140,000, whatever the population is. Can we validate in 2026 what that number will be? And if so, are we able to say whether the changes have occurred? So this population will look like this in 2023, but now in 2028, it's a different population. So those, and then the strategies that we're going to try to address to get at those populations, are they going to be reflected in the strategies that we have addressed here? As we talk about reaching out to the public, we talked about a meeting on July 12th, 13th, from 8 to 12. I know you've had community meetings, and I appreciate that, but are we not going to be having other ones at times other than 8 to 12, a work day with many of the people that we want to engage with are involved in? So I would want us to encourage considering other times as we go forward in looking at this. And I think the last thing is, and this is sort of in jest, is that we don't want to produce a product that is viewed as AI. We want to produce a product that people feel that we actually engaged in, and that we meaning us as a community, and us as a board, and us as the community have produced. So I'd encourage us that as we look at these kinds of questions that I've hopefully raised, and my colleagues as well, is that we're able to clearly identify that there are meaningful, deliverable, data-driven questions that we have answers to. So I think that covers most of the things I wanted to sort of mention.
Comments, staff?
I'm sorry, but you mentioned AI, and so I've got to take that.
In jest.
Well, actually, I'm glad you said that, and it should not be in jest. That's something I think that we need to be concerned about. And you're absolutely right. I mean, this was not an exercise where Danielle took 17 keywords and put it into something, and then out came this plan. It was not that at all, and there was a great deal of very deliberate, and I had the privilege of popping in on some of the work groups over the past several months. But, hearing the words, hearing the question being asked, what's equitable here? This is what the data show, this is what we heard, and I think, this is very much a human-centered and human-born product as anything that I've ever been around. And I think that, to bring that up from time to time is certainly the prerogative, but an imperative of the board to make sure we're just not in the algorithm business and just spitting out a number, not taking into account the human condition and the human voice. That's a powerful statement that you've made, so thank you.
Well, if I may just respond to
Sure.
by all means, I'm not trying to undermine. I think you've done excellent work, and I've followed you along the way. And I just use that in jest, but I do want to emphasize that for the common man or woman on the street to understand the dynamics of what we're talking about, I think we need to frame it, engage them at times that are relevant, and get them as part of it, is what I'm saying. And so that they, not me, but they won't think that this is a product of it.
Yes.
Yeah, no, and thank you so much. Yeah, that is a very, I mean, I know, and that's a profound and timely point, so thank you. One of the things I've got confirmation from our Chief Communications Officer that there will be at least 3 additional community conversations during the budget season at different times out in different parts of the community. So that is something that, is very important to us as well. And then also, before I hand it to Danielle to talk kind of about more some of kind of these conceptual approaches that are incorporated into the plan, I just want to remind the board that we do look at our comprehensive demographic report at least every 2 years. So we do get ACS data every year, so we are looking at these demographic changes and refreshing them pretty constantly. I mean, that report is still a fairly large lift, looking not just at numbers of people and the different incomes and the different demographics, but also burden of disease and geographically which populations are impacted across the community. And we do continue to see, these changes happen over time, and we are seeing people living in poverty continuing to expand to some degree in our community as folks are forced back into the county because it's the only place that they can find low-cost housing and that there are services provided. So as these surrounding counties and the outlying areas are also gentrified by some of the new business impacts that come in over time in areas like Taylor and Elgin and moving out in farther eastern parts of the county and in surrounding counties around us. So we will continue to update those numbers so that we can have a strategic comprehensive approach.
And I think to add to that, Manager Jones, because you had some questions around data and the population and the migration, one of the great things and the strengths of this plan is the data strategy and technology piece to all of this. So as we continue to build this out, we will have better access to data to track how our patients are doing and where we're driving improvement in outcomes and where we may see patients presenting with more advanced stages of disease, where we may need to refine our approach and some of the services that we offer to shift our focus and make an impact there, right? So we've done work, we've made an impact, and now maybe the needs have changed slightly and we need to just shift our approach again, which is the whole point of having this flexible, adaptable model that's meant to really evolve with the community. So we have the ability to drill down on the demographics at the census tract level. So when we look at those shifts in populations, we can easily adapt to those shifts and then looking at those health outcomes data to really understand what are some of those key drivers that they're presenting with, so those key diseases, and then what are some of those social factors that are influencing their outcomes. So this is going to have a continuous monitoring and surveillance approach to all of this to really assure that, it's not a one-size-fits-all. So how do we continue to better serve the needs of the community? And that will change year over year as we continue to make our impact.
And you're reporting how that's going to work.
Absolutely.
Okay. Thank you. Manager Brunson.
So, just so that I understand, of course, so it's almost as if we'll be operating two separate entities. The entity that you all have proposed here, but we're going to continue funding all of our usual funding sources, like integral care will still be funded on top of this, yes?
And this isn't an entity, this
Well,
is
I
a
know.
plan that we are so some of the things in this plan include expansions of funding for organizations like Integral Care, or expansions of funding in community care as we stand up Hornsby Bend, Colony Park, and Del Valley. So this incorporates both additional funding for services that Central Health may provide directly, and in many areas, expansions of funding for some of our contracted partner services.
And so the projected funding on here is all inclusive. It's inclusive of these new projects and includes the projects we already have in place.
So these
These
pages
numbers.
here
8 and 9.
are just the incremental costs for
That's
the
what I
new.
thought. So these are on top of.
Yes, that is correct.
And when we get the budget, we will see our costs on everything.
So it'll probably start with a forecast. You'll see at a very high level, everything combined into a bigger financial picture. And then the budget will show you for the proposed fiscal year 2024 budget, will show you again the entire entity with both, we'll call them ongoing plus any incremental costs.
Okay, thank you.
Management side, quick.
Mine is very quick, and it could be a question that we need to clarify. Who is our population, and what is this plan for which population that we're talking about? I think if we can just have I know we've talked about it, but to simply define our population and who this plan is for. And who would it exclude? I think because there is a larger discussion outside happening, so we would just want to make sure, who are we targeting?
So I think this plan has been focused on the population of Travis County residents with incomes below 200% of the federal poverty level comprehensively.
And does that include inmates of Travis County, or just?
No. We don't serve inmates.
So just wanted to clarify that when we're talking about Travis County. That is really my question.
Okay.
Thank you.
Yeah, we don't serve inmates. Manager Valadez?
Since I did, Dr. Bell, thank you for recognizing me. Very quickly, to our Central Health staff and Mike, because I did not get responses on some of the questions or concerns that I had with respect to the internal staffing or internal processes that are going to be modified in order to accommodate the move to an equitable system, and that would include staffing, et cetera, all these procedural practices. So is that possible for that to be provided? You know, we have all these additional projects that we're going to be wanting to incorporate into the health equity plan and our budget, but I want to see how Central Health and our system, which includes community care and Sendero, so it'll be the enterprise is what I'm assuming we're looking at. How is that going to be modified to accommodate these proposals, including these 158 and other necessary changes that may need to occur in order for us to level that playing field.
Yes, so if I understand if I could sum up your question, I want to make sure I get it right. You're really talking about the staffing levels and asking the big picture question of how are we going to get all this done, given where we are today.
And if so, could you tell us, just like you do how you've outlined into the various buckets, the different projects? Well, of those buckets of these projects, which of those are internal? Which of those are central health, community care, or whatever modifications or changes that may need to occur internally to make sure that we are able to implement and successfully complete these projects that will close our disparities gaps?
Yes. So there are some FTE estimates that sit behind, if not all, most of these initiatives. Some it's a little more difficult to measure because there's some staff reallocations that can happen as you get further and further out and have different skill sets. But in the near term, we can certainly talk about that. The other thing that I can do, and I want to bring this back to the executive committee, is I provide a state of the organization. If you'll recall, where we do actually address some of the questions that you raised, Manager Valdez, around where are we as an organization in terms of our staffing levels. And so certainly before my departure, I know we typically have that later in the fall, but I'll work with the executive committee perhaps on expediting that or bringing it up a little bit sooner and weaving it in with the budget process so that you can see the larger organizational changes. It is going to take a significant lift as an organization because we are going to grow substantially, and that's going to be very obvious when we bring the budgets to you later this summer.
Okay.
I appreciate that, Mike. Very quickly, Susan was supposed to have provided us something as she was leaving, and I don't believe I ever saw that, but I do know that in order for us to address health in an equitable manner and with that perspective lens in mind, that we also need, staffing is very important. And not just interpreters. I mean, staffing on site and how we provide services. So those are the kinds of things that I just would like to see. Thank you.
Yes, and that's part of the workforce demographics.
Yes, thank you very much.
Thank you, Manager Valdez. Any other questions? Thank you very much. Great discussion, great presentation. We look forward to seeing you in August. Okay, members. Agenda item number 2, discuss Central Health's ownership of health plan, health maintenance organization. Members, there's no presentation on this item, but we will have a discussion, and there's a discussion guide that's at your seat. I am going to start the discussion for the first section in open session because it's mainly historical and it's mainly facts that the public not only should hear about but has access to. The last 3 items deals with financial stability and financial fragility, and because of that, speaking in open session, if a competitor of Sendero, do we not have a quorum? We will pause.
Dr. Bell, may I ask for just a clarification?
Sure.
I don't have any of those documents.
Hold on.
Manager Valdez, we got to bring quorum back.
Okay. Go ahead, Manager Valdez.
I don't have any of those documents. I'm not seated at the chair. And so I don't know what you are referring to.
Brianna will send you a copy of the document that is actually in front of your chair. So you will get it very soon.
Thank you.
As I was stating, the last 3 topics we want to take in closed session because of the sensitive information that could provide competitors with information with regard to Sendero, and it could hurt us and Sendero if that information is provided. So what I will do, what you'll see on your document is a list of questions. I'm going to try to cover all of those questions. I'm going to need help from the Sendero staff. I have Perla here, and Betty DeLargy, the chair of the board, is also here to help me out. And I'm not going to go in order of what the questions are, but I will try to cover each and every one of them. And if you have additional questions, feel free to write them down so that when we get to the end of this, you can ask those questions, and if we have answers that we can provide you immediately, we will. So, looking at the document, our first discussion goal is to understand why Sendero was created. And Sendero, an HMO, was created during a time when we were hopeful that Medicaid was going to expand. That expansion would have allowed a large number of individuals to be eligible for Medicaid, and thus it would have been a sustainable market for Sendero to be in. Sendero also is a community health plan, and in Texas, a community health plan that applies for Medicaid is actually, in a certain sense, guaranteed a contract. Now, that guarantee is based on how good their proposal is, of course, and whether they are capable of implementing the plan, but they are given preference over the commercial for-profit plans that apply for Texas Medicaid. And then secondly, in the business plan was the Affordable Care Act marketplace. So it was thought at the time that we wanted to provide access to plans that were on the Affordable Care marketplace to individuals in Travis County, not done by a for-profit, but by a not-for-profit community plan that's targeting the population that that probably just don't meet our eligibility by much, but can afford to pay a premium and thus would have health care. So increasing the insured population within Travis County. Now, we wanted to provide access to the Affordable Care Act for eligible residents, and we also wanted to explore ways that we could provide coverage of eligible MAP patients that would have more access to services, mainly specialty services at the time, that would either save Central Health dollars or it would cost the same. So in essence, we were looking at a way that, is it possible to pay a premium and provide an extensive array of services for the MAP patients? Or was it better to keep them in MAP and provide the same services that we were providing them? And which could we do in a cost-effective way? And then it was most important that if Medicaid expanded, that we would get into the Medicaid market. So that's where the application sort of took place. Now, one of the questions that a lot of people have is, does owning a hospital or not owning a hospital affect the benefits that owning an HMO might have for the healthcare district? If Central Health owned a hospital, a health plan can create incentive packages to increase the utilization of their hospital and their clinical services, which would funnel monies back into the health district. So in essence, if I had a member, and if I told a member that by using the Central Health Hospital or going to a Central Health clinic, that we would be able to afford to provide you not only with the physical care and mental health care that you need, but we might add eye care, we might add dental to that. And many members see that value and will say, well, sure, I'll use their hospital and their services because I'll get an additional value out of that. And that's where the health plan actually becomes a benefit to the district. As you realize, we don't have a hospital. We do have a outpatient clinic plan, or I should say organization. And toward recently, I would say over the last couple of years, we've looked at ways to work with community care to determine how we might provide patients into their population and how that might be beneficial to community care. So an HMO does have a benefit for a health district, and it has an even, I should say, more prominent benefit if we had a hospital, okay? Why should we keep Sendero, and what benefits will Sendero provide in the future? Well, if Central Health evolves and at some point owns a hospital, then of course the model that I talked about could be put in place, and Sendero could serve and grow and enhance those assets. There are probably other aspects of having an HMO within our system as we venture into the direct care practice. I'm not exactly sure, and I can't outline exactly what those particular projects could be, but there is a benefit to having Sendero as a part of our organization. Now, there are a couple additional questions, and Betty and Perla might want to come to the table here, that talk about the benefits that Sendero offers to members, and you guys will be responsible for sort of talking about that. Welcome you to the table. Thank you.
Dr. Bell,
Yes, Manager Valentine.
how am I gonna get that? It's being distributed to everybody else.
We'll see if we can send it to you.
Thank you.
Anna me.
And I mean, right.
We'll email it to both of me and Manager Valdez right now.
They're emailing it to you as I speak.
Thank you.
What did I give you? This is a kind of a working draft document, so I hesitate to, Manager Valadez and Wani, if Brianna can send it to you, that might be best, because it's incomplete also. I think the question the specific question is, what benefits does Sendero offer to members that MAP does not? And we created this chart. Again, this is a draft document. It's a work in progress. I wouldn't say it's a final analysis. We didn't have enough time for John Morgan and Kit to add the map side of it. We tried to fill in, just in the spirit of trying to be helpful, we filled in what we were aware of just based on an online map handbook. So there's the chart. I think further analysis of this will come out of the CHAP study that we've mentioned to you. But we did try to do our best at pulling a draft crosswalk together. And there's a lot more detail than this chart provides, but I think it begins to give you a sense of the comparison of benefits. What else can I give you? What's not captured in the chart of medical benefits is case management and navigation. They're not benefits per se, but they are services that we provide to members that they can opt in to receive. And these services are voluntary. However, every CHAP expansion member is assigned a community health worker who serves as a navigator and patient advocate and who conducts regular assessments, including upon enrollment in the program, we make referrals to nurses and social work case managers based on the members' needs and desires. So I'm going to talk about the Sendero. I can just quickly go through some of the Sendero benefits. And again, I really think it's best if, John Morgan or Kit or maybe Jeff can speak to the MAP benefits. Sure. But you see here a list of pharmacy. We do have pharmacy benefits, and there's a separate chart for that. Primary care visits to treat an injury or illness, and that includes pediatrics. And some of these at the front end are services that MAP also provides. Specialist, other practitioners, including nurse, physician, and assistant. So on the left-hand side, you'll see are the Sendero benefits, and then we might have put some notes after that, and then the third column are what we saw online as a MAP benefit. And then we may have put some notes on the fourth column. We offer outpatient facility and ambulatory surgery benefits. We have outpatient surgery, physician surgical services, hospice, urgent care centers or facilities, home health care services, emergency room services, emergency medical and transportation and ambulance, inpatient hospital services, inpatient physician and surgical services, skilled nursing facility, limited to 25 visits per year, prenatal and postnatal care, childbirth delivery and all inpatient services for maternity care, mental behavioral health care outpatient services, and inpatient hospital services, substance abuse disorder outpatient services, substance abuse disorder inpatient services, outpatient rehabilitation services, chiropractic services, durable medical equipment, hearing aids for adults, hearing aid or cochlear implant and related services and supplies, imaging, preventative care, screening, immunization, annual well woman exam, annual screening by low dose mammography, for the presence of occult breast cancer for females. Bone mass measurement for the detection of low bone mass to determine risk of osteoporosis. I'm on page 5. Routine annual prostate cancer detection exam. Routine foot care. On page 6, routine eye exam for children, 1 year and under, but adult vision benefit is not something that's covered. Eyeglasses for children, but not for adults. Adult dental benefits are not covered in this plan. In the CHAP expansion platinum plan, dental checkup for children, however, and rehabilitative speech therapy, rehabilitative occupational and rehabilitative physical therapy, well baby visits and care, laboratory outpatient and professional services, the administration of whole blood, including cost of blood, blood plasma and blood plasma expanders, x-rays and diagnostic imaging, basic dental care for children, orthodontia for children, major dental care for children, not for adults, transplants, accidental dental, dialysis, allergy testing, chemotherapy, radiation, diabetes education, prosthetic devices, infusion therapy, treatment for temporomandibular joint disorder, nutritional counseling, reconstructive surgery, mammography, cardiovascular disease, osteoporosis, diabetes care, management, inherited metabolic disorder, post-mastectomy care, brain injury, transplant donor coverage, autism spectrum disorders. And in many cases, and that's the list that we have, in many cases, the benefits that are provided by a regulated health plan are established by our regulators, and so we must adhere to those guidelines. Let me see if there's anything else here that I want to cover. Yes.
Before, as you look to see if there's anything else,
right.
The Platinum Off Exchange Plan
Yes.
is what we place the MAP patients into when that meet a high risk score.
Mm-hmm.
We place them into that plan and pay a premium for them. Correct?
Correct. So, yes.
And
so the MAP members, certain MAP members are placed into the Platinum Plan, and Central Health covers the co-pays, the premiums and the co-pays. And that is on page, I think we put that on page 13, no, page 13, it's MAP. Okay, that's not on here, but yes. Oh,
I think it's
here
on
we are.
page 8.
Page 8, you're right.
Yeah.
That 13-page document. So you are correct.
And just for the members, what MAP offers is in the third column. So if you look at the very first page, you'll see the headings.
No, it's not.
It is not complete.
It is not complete. John?
I just want to point out to the board.
Sure.
Central Health staff have not provided a list of MAP benefits.
This is what it shows.
Good afternoon. Thank you. So just to point out to the board, Central Health staff have not provided any input into this document at this point. So
Okay.
this is not a analysis or representation of MAP benefits. We'll have to do that due diligence.
Okay. And actually, I'm speaking for the person who asked the question, but I'll let her speak for herself. In essence, I was under the consideration that anytime you get any insurance plan, whether it's MAP or Sendero, you're given a list of what services you can utilize based on that premium. And that happens, right, John?
So MAP is a little different, and we take a deliberate approach to not overwhelm our members with pages and pages of CPT codes and a maze of things that they have to navigate to figure out if their services are covered or not.
Okay.
So when you look at a MAP member handbook, it's a few pages. It is not 100 pages like a commercial insurance plan would have a list of your covered benefits and have a list of every provider that's in their network.
Okay.
When we enroll individuals into MAP or MAP Basic, they're assigned and select a primary care home, which is primarily one of the 3 FQHCs in our system. And really our FQHCs offer an advanced level of navigation services for our patients to help navigate the system. So that patients aren't left to do that on their own. So when you think of services like specialty care or post-acute care, we don't necessarily market those directly to patients. Those are services that primary care providers will help navigate people to. We want people to understand how to get into primary care and get established, and also how to access acute care services like urgent care, hospital care, how to access those services as well. So it's a little bit of a different approach so that we can really not overwhelm people and try to make the system as easy to navigate as possible, which is why we probably need to do some due diligence on this document.
Sure.
We do not put on a website or in our handbook a comprehensive list of all of the benefits in our network.
Okay, great. And really what you're saying is it's done on purpose because of the population we serve.
Yes.
And we want to make it as easy as possible for that
Absolutely.
population to be able to really access primary care, and then our navigator services kick in, and if they need additional care that's covered by MAP, they'll navigate them to those services.
That's correct.
Okay. Any questions, or Dr. Martin? Sure. You do need your mic.
Yeah. So I guess just to clarify, what services are provided different through Sendero? I'm thinking about us taking on a risk related to that. They're not provided, so we just put them in an HMO, number one. Number two, I saw about the deductibles, right? So if you're going to have surgery at a dermatologist's office and they want Mohs surgery and it's $3,000 charge and your deductible's $4,000, they won't touch it till you hand them the check for the. How do we handle that for our Sendero patients? So number one is, how is it different? Aside from the social wraparound. And two, what do we do about deductibles with our patients? Not copays, deductibles.
So how is it different? I think that's what we're talking about here is, Sendero has several different plans, but what we're focused on here with this chart is the Platinum plan, which is where the former MAP members are transferred to, right? CHAP expansion program. So we have provided the list of benefits that Sendero offers under that plan. I think what John Morgan is trying to say is that we need to do a little bit more due diligence to be able to compare how that Platinum plan compares to the current MAP program. And we will have to follow up.
What I'd also not just about the MAP program, but how does it compare to just another HMO in terms of cost and us assuming the risk associated? I understand the social issues related to being in Sendero that are better, but
You know the deductible on Platinum? I think that's what he's asking, is you go to a doctor's office and you've got a large deductible that they expect to be funded.
They won't
But
touch
these
it.
are MAP members who Central Health is picking up the deductibles and copays, so how do we handle that administratively?
My understanding is that, and Jeff might speak better to this, but there are no Central Health covers.
if someone has a Sendero plan, there's not a deductible,
Well, it depends on the plan, and the
No, no.
Platinum plan is the richest plan.
but there's still I saw a $4,500 deductible.
Right, and somehow, so the calendar deductible for the Platinum off-exchange plan This says 0 if they're in network. On the chart on page 8. So if they go to a network provider, so someone who is on this Sendero network, and somewhere in this material, there's a comparison of the number of providers
Okay.
available.
Well, we're framing the question then, out-of-pocket limits. So they have a $28,000 surgery. They have a, how do they come at that $4,900 individual? Do we handle that, or?
I don't have an answer to that, and I don't know if Jeff might have a response to that. So that's more on the financial side. What I do know is, and this might be related, is typically the platinum member claims are much higher than our regular ACA members, and I can say that.
Thank you.
Okay, let me try to answer, if I understand. And I don't know on the benefits, but the platinum plan, the example you're citing, there are really no out-of-pocket costs for the members in the platinum, the high-risk plan. So, sorry.
Can you speak closer to the mic?
Okay, so there are no out-of-pocket expenses, co-pays in the platinum high-risk plan. If that's the question. My apologies, I had this stuff out.
So they never hit the limit?
They never hit the limit?
No, it's 0. I'm saying it's 0.
Manager Kitchen.
And I hope
I think the question I'm hearing, perhaps, Dr. Martin, is
Help me.
basically what, if I'm understanding correctly, what we're doing here is we're purchasing coverage through Sendero. So what does Sendero do that if we purchase coverage through another plan on the exchange, what are you doing different? Or are you doing anything different in terms of the benefits? So the platinum plan, and tell me if I'm wrong, because I don't know all the details, but the platinum plan under the exchange has a set of required benefits, right? And so all the plans that are offered under the marketplace, or whatever we're calling it, under the marketplace would be the same set of benefits because they're required. So if we bought coverage in another plan other than Sendero, how is Sendero doing anything different than if we did that?
Are you saying if you bought it from a different HMO?
Yeah.
Well, Sendero wouldn't have anything to do with it because we.
No,
we-
I mean, I'm trying.
Comparison.
Oh, okay.
Why
The difference would
Sendero,
be-
not
okay.
Blue Cross?
Okay.
Right.
Well,
I'm sorry.
Well,
for one thing,
yeah, go ahead.
you would be paying money to, Central Health would be paying premiums to Blue Cross, and although Blue Cross is, on paper, a nonprofit, they are some of the highest premiums on the exchange, I think, right now. So you would be funding someone else's health plan. One of the reasons Central Health does this is because Sendero is a wholly owned subsidiary of Central Health.
What's the benefit of that?
It supports Sendero's reserves and capital and surplus because this is money coming in that supports its overall business.
Yeah, I get that, but why? In other words, why? We're not here to support a business, we're here to support the members. So what is it that comes with supporting Sendero for our members that is different that we might get than what we might get if we bought those services from somebody else?
Well, I think it's a question of Sendero's outreach to the community and Sendero's local touch for these members that you might not, that's one thing. It's a little bit non-quantifiable of their ability to manage these members in the community and actually provide more of a personal touch. I mean, that's not quantifiable and I think it is valid. The second is that I'm not sure that another health plan would offer you this 100% coverage, this platinum plan, possibly because the platinum plan with the MAP members moving over is somewhat built on a complex financial model that I would rather Jeff explain, because it has to do with the whole risk adjustment program and moving the high-risk MAP members over. What it does get for these MAP members is it does get a much broader selection of specialist providers, and we can, argue that, but if you look at the numbers of providers in the MAP network versus the Sendero network, the Sendero network does have a greater number of providers available. Anecdotally, we get information back from the Sendero members that they are able, the MAP members who've moved over, they are able to access services quicker. One of the reasons we're doing this study of CHAP versus MAP is because all we had right now, or so far, was anecdotal information. We really wanted to see, is there a difference in the quality of care that these MAP members who were covered by Central Health, is there a difference in care when they are moved over to Sendero fully insured? And that would be based on the provider response to a fully insured plan versus the provider response to the program provided by Central Health.
Right, and I get that, but and MAP, I think there's a prejudgment bias because of the MAP patients that all they're seeing are severe MAP patients, right? These doctors, but the issue gets back to being, since we don't own a hospital system, how is it truly different? Of course, it's better than MAP, absolutely. But the issue, is it better than, yes, we incur some additional costs by buying a private plan for our patients or people that we serve, but we also incur a lot of financial risks, a lot of other things that were not tangible benefits to us without a hospital. And the question is what benefits are truly different aside from the slight increase in premium we pay in support of these patients? What are the greater benefits that they have to be matched up by law, the benefits that are provided?
Right.
Platinum to a platinum.
Right. I'll start out on this, and then if I may, then hand it back over to the table. First of all, we don't have any evidence that shows that Sendero Ideal Care is better than MAP. In fact, that's one of the reasons why we're engaged in this ongoing analysis is to look at the health outcomes. In fact, there are some individuals, not many but a few, that actually have come back over to MAP from Sendero Ideal Care because it was preferable. It worked better for them. And when you look at it from outcome to outcome, we don't have anything that shows that, again, an insurance product does better than MAP. In fact, we would argue that MAP does better than a lot of insurance products because we don't get hung up on all the things that insurance companies can get hung up on. I'm not saying Sendero does this, and I think they're very generous with their medical necessity reviews. But getting back to your point, at the end of the day, when you look at all the products that are on and off exchange in the metal plans, especially as those plans are now consolidated, because there's a lot of different plan designs out there, and those are being consolidated. The actual insurance products themselves, and this is my opinion, they're pieces of paper. They're commodities, and it's really hard to tell from one company to the next when you line the papers up. What's really different. So especially here in this market, you have Seton or Ascension and St. David's hospitals in your network. Yes, check. Or you have Austin Regional Care. Yes, check the box across. And so, again, there's not a whole lot of differences where you are competing, and Chair Delargy is right, is really on the margins, and it's around customer service interaction and engagement, and the navigation services, the culturally affirming care, being able to reach out to people. That's the value difference, and I don't know that I'm adding anything, but I'm just maybe saying it a little bit differently.
Let me add to that, Mike. In a recent survey we did of our employees, I think one of the number one value that our employees listed is commitment to the mission the nonprofit mission to serve our members and to focus on our community, helping to serve our community. And so, I mean, we are a small local plan. We are at the neighborhood events. And so I think there is a high level of commitment to community service and helping our members find a solution. And I've heard several examples of that in my short time at Sendero. So I would say that that's a benefit. And if there is an issue, it's a, you know, kind of within a small organization, you can pick up the phone, call somebody, and find a fairly quick resolution, and not, you know, have to work your way up the chain. So, I mean, I would say that is a benefit.
So if I could add one thing, I think this is right, or it was right at one point. The Sendero plan is the only off-exchange platinum plan. And so you might ask, well, what's the benefit or why? Well, we're trying to manage a high utilizer, high risk. And when you're off-exchange like that, citizenship isn't an issue. So we're really looking at trying to manage high-risk, high-utilizing patients without citizenship regards. So we're really managing our population in a way that makes sense to take a group based on conditional, medical condition examples and move them into a program that is beneficial for our lives.
Well, thank you. That's a very good point. I appreciate that. But one caveat, and I won't go on, is the last meeting we had was a financial issue surrounding Sendero. And I think that is an issue I think that we need to weigh as yes, there's wonderful things about it, but the pragmatic issue surrounding having a small program without a hospital district and where we need to navigate with that. But
And we'll cover a little bit of that when we go into closed session about the financial part. Manager Kitchen.
I think this goes back to something Mike said, just that I want to clarify. So, and I know you guys told us that there's a study underway right now, so I may not be remembering the scope of that. But I'm concerned a bit because we don't have the data, and I can't make a decision just based on anecdotal. I mean, for example, and this may be what the study is doing. I mean, outcomes data, like HEDA's outcomes data, for example, should be a fundamental piece of information that a plan has. So do we not know, does Sendero not know what kind of outcomes we're achieving for the population? So that would be one question. And I assume when we're comparing, I don't know, I can't remember, I'm sorry, you talked before about the scope of this study, but I'm assuming that would be one aspect that we would compare, right? Is medical outcomes?
Yes, that's one of many. I'm sorry, that's one of
It
many
wouldn't be the only one.
aspects. It wouldn't be the only one, but
Does Sendero not have that data
We
now?
do have that data, and we presented some of those measures, outcomes of those measures at the last board meeting. That was that presentation that Dr. Jennings.
How does that compare to,
We presented a few highlights of that.
Okay.
How does that compare to MAP? I think that is part of this,
That's
what
part
the
of the
study
study.
will
Okay.
unveil.
Okay.
And I think, though, the MAP, the CHAP expansion program is still a young, a startup program, and it was 2018 or 19. So I think in terms of health outcomes, I think it takes time to kind of see what the benefits or the improvements are. I don't know that we have enough data yet, but I think we could potentially begin to see some.
Yeah, I would think, I think 2018's long enough to have some data, but that's okay. I'm sorry, I forgot that you all had mentioned that to us before, and that'll be part of the analysis, so that'll be useful to see once y'all finish that. I think that's an important, an important analysis. So if I may I ask a few questions about the care management? Okay, so you all, so you mentioned here that every CHAP expansion member is assigned a community health worker, and do they do the assessments with every member?
With the CHAP expansion members, we attempt to make an assessment with every member.
Okay, and that assessment determines, well, I guess what I'm trying to get at, does every CHAP member have a case manager assigned to them?
They are assigned. Now, some might decline, but we try to work with them as best as we can to encourage, utilization and.
Sure. Do you have data about that program that we can see? I mean, is that part of the comparison with the MAP program? How well the care coordination case management is working?
I think you have that data though.
Is that within the scope of the analysis of the comparison?
That was in the scope of the analysis. Do you know, John? Okay.
Is it part of the analysis? Okay, well, that's fine. That'll answer the questions there. I just wanted to verify it was part of the analysis. So, okay, thank you.
And members, if I may, this analysis that we're referring to, you got a preview of what it looked like a few months back, but obviously as it is worked through over time, it's got to come back to this board so that we can present this information to you. But one of the strengths of what I feel like the teams have put together from both Sendero and Central Health is that it's got this timeless quality about it, because you can use this same framework to come back and keep assessing, because and that's something that every enterprise needs to do. You need to step back and assess, hey, what's our approach here? Is this still directionally right for us and for more importantly the people that we serve? And so it's not just a one-time analysis. This is a structure that will enable continuous deliberations for the board.
And can you remind me, I'm sorry, we talked about this before, but I'm not remembering the timeline for the analysis.
Just as you asked that, neither am I. So we'll work through the we'll make sure that it's on your future agenda calendar. So
I know it's going to take a while.
It is going to take a while because obviously we're launching
First two are starting now.
Okay.
And those two will run to completion within the quality longitudinal analysis so that it's likely a multi-year study.
Okay, so approximately when might we see some, and again, I know we're retreading ground, but I apologize, I'm not remembering anything. Is it later this year? Is it the first of next year? Just order of magnitude.
So the first two work groups that are just now forming, they'll do their work over the next couple of months.
Okay.
Conclude that first set before the end of this fiscal year.
Okay.
And those are really focused on the plan comparisons, the network comparisons, the benefit comparisons, the patient financial responsibility comparisons, and then an optimization strategy for how and who we enroll into that CHAP expansion off-exchange plan.
Okay, and then the care coordination case management.
That would likely be part of the CHAP expansion analysis, but also part of that longer-term quality analysis.
Okay, I mean, that's one of those things that can be a difference, but it's also one of those things we need to measure, because that's one of those things that you can see a big difference between a for-profit plan and a nonprofit plan, the degree to which they're actually engaging with members, the effort they make to actually reach out to members, how hard they try, is it 3 times, 4 times, 5 times, whatever, but that's all measurable. And so I think that's something that I think it would be important for us to understand. So.
Okay. Manager Kitchen, there are a couple of questions that are continued answered on this document that deal with relationships with community-based organizations.
Okay.
And housing instability and insecurity. did you want to just read this information on your leisure and come back and ask questions, or did you want them to present it, or?
I can take a look real quick if you want to go to other folks. And
Okay.
ask if I have any questions. So,
Any other questions or concerns, Manager Jones?
I'll be honest, I've been on this board 6 years now, I think it is. I still have some challenges understanding why we're in this business. But I'm going to leave that for another conversation, for another time. Are there other hospital districts in the state that have hospitals, have health plans?
Mm-hmm.
And so the question is, we do not have a hospital. So, and thank you for providing this, gives us a lot of information to catch up on, and I should have done a lot of this already. I'm just trying to ascertain, if we did not have this plan, who would suffer? Who would not be benefited? Who would not be able to get health care from the hospital district under our model?
And I'll take a stab at that first. Do you remember that hearing that we had when we were ready to wind it down? And all of those people came in and they testified to us as to what the health plan had done for them. They had had cancer, they had had surgeries, et cetera, because we had made the decision that we were going to wind it down. Those are the people that, if we didn't have that health plan, those individuals are the ones that would not be served. Now, they could, and I think I know what Dr. Martin is going to say, is that they could go to a different health plan. But ours at the time, was the lowest cost, and it was looked at as a community plan that had a very high touch to those individuals. And so they felt sort of a we're not enclosed, so we're not enclosed. And so they had there was a commitment to Sendero. And that's why they lined up to tell us why that health plan should remain open. So those are the folks.
Okay, now, go ahead.
In addition, you might see some of the people that have come in through HEM and SEMS fall out because they are funded by subsidies that other carriers are not required to accept and might refuse to accept.
Good point.
You know, Sendero has special programs that allow acceptance of premium from third parties that other carriers will not accept. They're not required to by federal or state law. There's very limited funding they have to accept. And if you looked at some of the other carriers, they might say, no, we don't want that risk. They won't say we don't want to cover musicians, but they would say we won't take subsidies from HAM or SAMS or some other nonprofit that's not one of these specifically itemized in federal law. We are required to take subsidies. So you could have a group of people that fall out because no one else will take them with subsidies. It's not a huge group of people, but I don't know what the population is for HAM and SIMS, but they could drop out as well. They come into Sendero, how many?
It's about 1,000.
1,000. They come in through the exchange, but they could be looking for coverage if Sendero was not there.
And I'm not opposed to the plan. I'm just having a problem understanding as a hospital district, without a hospital still, is this the business that we should be in? And if so, could we do a better job of making sure that the entire community understands all of the all of the benefits derived, and are we doing a good job in doing that across the board? If we're going to be in the business, we should do that. If we're not going to be in the business, then we should not be in it. So that's where my dilemma has been.
Yeah, I'm not arguing with you. I was just pointing out who else might lose coverage.
Right.
But I absolutely agree with you on that point, that we need to do a better job about making it clear to the community where Sendero fits, if Sendero is going to be here.
And who's in the community that could benefit that is not, because they don't know what Sendero is, or they don't understand the whole concept of a health plan. So those are the kinds of things I'm just saying we need to do a better job of if we're going to continue in the business. I'm not opposed to it. It's just that if we're going to do it, we need to do it that way. So never mind.
Yes.
So if we were to add up all the money that Central Health has had to put up, or in these last, since Sendero, and we were to look at that and roll that into our cost per patient, how high would that cost go? Because if we're spending whatever, $5,000 or something a year, but if you add in all the expenses that we have already had to come up with to support Sendero, what would that number be per patient?
So I don't have the number by patient, but it would take a little while to get that. That would be over 10 years of data. So, but what I do know is over the life of Sendero, Central Health has invested a little bit over $108 million. In addition, there were $2.2 million of startup costs that were reimbursed to Sendero during the startup. So I don't know what per patient or per member cost would be. We could calculate that, although the membership wouldn't correlate necessarily with the capital timing, so it would be over a 10-year period. Here's how much, and here's how many members we've had, and it's irrelevant of metals, which is another confusing aspect, because bronze membership is a lot different than platinum membership, which is a lot different than our high-risk program. So there are a lot of elements that, mathematically we come up with a number, but I just want to make sure I caveat that if it's a per member cost, that there are other elements of that number that may or may not be reflected.
Well, and I asked the question, of course, to say, well, if it's actually not $5,000 a year per patient, then it's really, if we were to add into all of our extra costs, that it wouldn't be cheaper to go with another, just not use Sendero, but use somebody who already is on the market.
If I may, Jeff is wisely and prudently being very, very precise, and I know the board has the good sense to listen to him, but I'm going to humor you with a little bit of Aggie math to try to answer your question. So if you take 108 million rounded, which is a combination of the surplus debenture, which is a debt instrument, and the paid-in capital, which was roughly, of that 108 is 71 million. Let's just assume an average of 12,000 members per year. And obviously it's a lot lower now, but at one point it was a lot higher, because and that includes the Medicaid population that once was insured. That comes out to $818 per member over the life of over those 11 years. So over $800 per member. Yeah.
And I would say that we probably paid out a lot more in services for those members, some of those.
Especially on the Medicaid, because
Medicaid.
of the premium deficiencies.
Correct. Manager Musite.
Appreciate it. Look forward to a completed draft that has your input and math folks as well. I think our mission as Central Health is providing access to our low-income, underserved communities, and I think this fulfills our mission of providing access to care. And we know that individuals who without access to care, they won't be able to utilize any of the services. And the benefit of Sendero is that they have access to specialists and outside services that are not really available to our only MAP patients, correct? So that is a benefit of the Sendero. Now, in terms it comes to why and how and the cost, healthcare is expensive, and I don't see the state of Texas expanding Medicaid anytime soon. And so we need to think of innovative ways and how to provide more access to individuals. And it is, and another thing that we are trying to do a lot as a Central Health, and that is something, a discussion that we need to take upon us. Where should we focus our efforts on providing the greatest needs and the greatest access to our patients? So that is a thought that I just want to engage my members on, because in order for us to do a great job, we need to be focused, centered, and not to spread ourselves too thin. And that is just a deeper discussion on everything that we're trying to do for the future. But overall, our mission is to provide access to care for those who need it, and this provides it. And I understand we have been in discussions. I was present that we had that meeting, that special called meeting on a weekend, where community members have expressed how much this care meant to them. And it was, to us, it may have been a price sticker, but to them, it was their lives. And that is priceless. So I just want to end it with that. Thank you.
Okay, Manager Kitchen, and then Manager Martin. And then Manager Valadez, I'll call on you too.
I agree, and I think we all agree that our mission and our concern as provider is access, and making sure that people get the care and going the extra mile, because that's what we should be doing in this organization, and we can do that, and that's our mission. We're the only ones that do that. I think we had some conversation about that earlier with regard to the plan. The concern is I'm having difficulty operating without data. I'm having difficulty operating without results data. And these are measurable things that we're trying to provide. And until we see that we are actually accomplishing what we want to accomplish and we think we maybe are accomplishing, then we don't know. So it is an important piece of data of what people came and told us about their experiences. That's really, really important. But it's not the only thing, and it doesn't tell us whether we can't provide that same kind of service through MAP. So I'm at this point, I'm looking forward to seeing the analysis that's underway. That's the kind of information that I need to see. I need to see results.
And I think we all need to see that too.
Yeah.
We agree. Manager Martin.
So I completely agree with you, Manager Satsi, about our mission to serve, but we serve two masters. Our patients that we serve, but we have fiduciary responsibility. And all I'm asking is that we keep our ears to the ground about that. And I think that if the reality of a hospital becomes a reality, a much more reasoned discussion could be had about financial responsibility. I think that we have to be attuned to that, and that's all I'm requesting. I'm a big supporter of Sendero, but I think financial responsibility is important because the taxpayers are watching.
Got it. Manager Valadez. You're on mute. You're on mute.
I really appreciate the conversation about Sendero. Of all the hospital districts in Texas, one of the pieces of information that I was going to provide to you at our last meeting was that Sendero is the plan that offered the least amount of services to the patient population. And there was a comparison that came out of that Texas Coalition of health hospitals and community healthcare districts. That's standard Texas data. In addition, Sendero, that you can't get away from the value that organization has to providing services and comprehensive health insurance to the working poor in Travis County. Now, you can try and go deal with Blue Cross or anybody else, and I promise you that you're going to have to run around in circles for days or weeks before you get an answer. because Sendero is locally owned, it's in-house, it's right down the street at the corner of Burleson and Van White, you can go in there and talk to whomever you want and get an answer today. If you have a question today, you cannot, as a parent of someone who is sick, you cannot quantify that. That is just immeasurable. So that's something I have to say about Sendero. You know, they have not always been in the best financial position, but you know what? Who cares? And I'll say this, why? Because they are providing medical and hospital services to their patients, to patients that are our patients and are working for patients. That's why they went to Sendero, because they could afford Sendero and they knew that they were going to be able to have access to a live body as opposed to a computer at some of these other call centers of for-profit and alleged not-for-profit corporations. Another thing, you cannot measure, again, their commitment to patients, their employees' commitment to patients, the fact that they work hand in hand with Central Health and with Community Care and with all the other organizations in Travis County and even around Central Texas. And so that is important to me as a patient. I used to be a Sendero member. I used to also sell Sendero when I was a federal navigator. And I can tell you right now, there was no program, no plan that that offered as many services as Sendero did. And like I said, they were in-house and you could walk in and talk to someone, or you could call them on the phone and get an answer. If nothing else, you could call Central Health, and Central Health would pass you on to them. With respect to the financial cost, we have been giving millions and millions, almost over $1 billion to the University of Texas. And what have they provided to our targeted population? 4% of clinical services? Sorry, Charlie, that doesn't cut it. So if we're going to do that kind of deep dive, which I think we should to Sendero, I think we should do it to everybody else that we're giving money to. If that's the way we're going to be, the standard has to be to everyone, not just pick and choose whoever we're going to do a deep dive in and check to see what benefit we are getting or what the cost of care is for that person or for our patients. Because I think that really is a conversation worthy of discussion by our board. And if it is had, I think we will be surprised to find that that's probably one of the better programs that's being offered with respect to healthcare in Travis County or Central Texas. I can't say enough good about them, but I also cannot say enough good about what Central Health is doing or Community Care. I will be concerned about some of the other organizations that we have funded, and but that's a conversation that we should have at the board, and that's also a conversation that we should. I mean, that's a standard that we should force all organizations to abide or adhere to, and creating that standard is what we should be doing so that we don't have increased disparity gaps, increased problems, increased complaints about what we are doing at Central Health. And I think the public, that would grow a lot of trust in the public arena if we support our organizations and not just, oh no, it's time for us to go to Blue Cross, or let's go to Superior, or let's go somewhere else, as opposed to what we created, because Central Health originally believed that was what we needed. And I still believe that Central Health, I do believe that we do need that. Now, there may be board members that don't and have been prepared to jump ship for a long time. Not any necessarily here, but previous board members. I know I had those fights with them in board meetings. But like I said, if we're going to have a conversation, let's have a conversation with not only about Sendero, with some Sendero staff here. I would like to see the old timers at Sendero come and talk to us about what they know off the top of their head, as opposed to having to look at a piece of paper and decide, oh, this is what we're doing. Because I know some people over there, Betty and Ellie, who could come over here and probably respond much better to your questions, because they have the history, they have the historical knowledge, and they're there doing this every day. So
Thank you very much. Appreciate it. Okay, I will now go into closed session. And, yes, sir. If any of the other members, if there's one of, you have to leave at 4? Okay. Then we'll probably have to take this discussion up at a later time. No, that's fine. No, no apologies needed. I'm glad you said that. So, in essence, we'll table this until another time, and we'll come back and talk about the financial stability issues and address some of the issues that Manager Valadez outlined. I happen to be an old timer with Sendero, and so does Mike. And so we do have information that we can share. So I will now go to agenda item number 4, confirm the next regular board meeting, date, time, and location. Managers, our next Central Health Board of Managers meeting is tentatively scheduled for Wednesday, July the 26th, 2023 at 4 p.m. at Central Health Administrative Offices, 1111 East Cesar Chavez, Austin, Texas 78702. At this time, I'm ready to accept a motion for adjournment. Manager Martin moves adjournment. Manager Jones seconds. Any further discussion? Hearing none. All in favor? Aye. Any opposed? We are adjourned.
Did you want to